do we make that barrier safer, bigger, better, more robust? Use your own words, whatever. Don't you love it? Exercise. God dang it. Why do they always come back to that? But the fact is, exercise.
Zumba.
Secondly, Zumba. There you go. Stop smoking. Duh, right? Diet, we're going to talk about that. And then there's some very specific drugs that we actually use. And these drugs have been used for a long time. The angiotensin inhibitors, the ARBs, the angiotensin receptor blockers. You know them as lisinopril, Zestril, Ramipril. You know them as Avapro, Diovan, Benicar, those drugs. Now, what we've done and what you'll see here is that many people who have diabetes, normal blood pressure, okay? Normal blood pressure. But we already know that endothelial function is going to break down. So if you start with a very small dose of some of these drugs, you can keep that barrier intact and you preserve renal function. So many of you ask me, but my blood pressure is fine. It is, but I'm protecting your kidneys. That's what I say. That's what those drugs are about. Okay? So they're more than blood pressure drugs. And we can go into it at a later time, but indeed they've been shown to decrease the onset of diabetes as well, all kinds of things. So they're known as blood pressure medicines. When the government comes out and says, you know, any blood pressure medicine is fine, it's not true. These drugs do a completely different thing than, for instance, beta blockers, metoprolol, Coreg, propranolol. Those names ring a bell? They do not change endothelial function. They do not improve endothelial function. I can't be more clear. They have a position, they have a point, they're important. This is not what they do. It does make a difference. You choose drugs for a reason. Endothelial function is why we choose ACEs, ARBs, calcium channel blockers, usually in that order. Okay? A really important point to take home. Next, please. Statin treatment. Now, everybody that I put on statins, usually they try to give me an excuse why they can't take them. Right? You've heard in the media, they hurt your muscles, oh my God, it's going to kill my liver. I have to push and prod. But I wanted to use this time to really show you that they're really safe. They are the most commonly used drug in the world. I think Lipitor is now the most commonly used drug in the world. And you just don't see bad things happen. Of course, people can walk across the street and get run over by a car, so things do happen. But these statins are relatively safe. They reduce risk substantially. You're 2.78 times more likely to be dead in 1 year if you stop a statin. Now, why is that important? That's important in today's marketplace because that's what's happening. The drugs are expensive, or people's formulary changes because of all this government hoopla. What happens? The green pill becomes the blue pill, and Aunt Martha, who's 84 years old, doesn't understand that the two are the same. She doesn't take it. She dies. And there's a substantial increase in people who have stopped their drugs, substantial decrease in meeting LDL goals, and a substantial increase in the number of heart attacks and strokes only because people forget to take their medicine, purposely don't take it, or don't understand to take it. Compliance is very important. This is one of those drugs that when you start, depending upon your risk and the circumstances, obviously, you don't just stop it. Okay? Very important. They are safe. Rhabdomyolysis is when there's muscle breakdown. It is rare, not uncommon, rare, really rare. Statin myopathy can be treated with CoQ10, and I've told many of you to take it. You take 100 milligrams a couple times a day. We watch your LFTs like a hawk. You know, we're watching your blood all the time, but it is rare that it ever happens, but it can. So don't be stupid. We check, right? And it's the elevation in LFTs are dose dependent. And you may have seen recently, everybody has the scare again about Zocor or Simvastatin at high doses. Check the liver. How hard is that? Not hard. Next, please. Medication saved lives. This shows you how you can see that the person with the statin on the right has significant decrease in risk. They absolutely save lives. Next, please. Now, here this is just, I can give you these, but you're probably not interested. This is all the medications and what they really do. So if you have an elevated LDL, your risk goes up 2 or 3 times. These are the various treatments and what your goal is. Elevated small dense LDL, we talked about that before, those small LDL molecules that can get inside the blood vessel wall easier. You treat that with niacin first, fibrates and statins. Again, diet and exercise, you might see that come up quite a bit. I'm sorry about that. Low HDL2B, in other words, you don't have enough of that big fat HDL molecule. Again, niacin, diet and exercise. Elevated Lp(a), that's that inherited molecule that I was telling you about. Niacin is really the only thing that helps. Fenofibrate doesn't really help too much. Statins and carnitine may be a help. And elevated triglycerides, once again, diet and exercise, diet and exercise, diet and exercise. Next, please. This gives you an idea of what the effectiveness of those various treatments are. So when you use a statin, you can decrease the LDL by as much as 50%. Sometimes more. I've seen LDLs go from 200 to 60. I mean, whoa, right? HDL goes up, not with many of the statins. The one statin that really allows the HDL to go up is more Crestor than any of the others. Most of them really do lower the HDL, in truth. Nicotinic acid, of course, is their nitrates, and fibrates are on the right. And as you can see, the fibrates may in fact decrease insulin resistance. The statins don't have any effect at all on insulin resistance or diabetes. So it's not the be-all and end-all for the person who's the diabetic. You may need something else. But it's pretty effective at working with triglycerides, at working with HDL and LDL. It doesn't do much with a small dense LDL. The only thing that really helps that are the nicotinic acids and the fibrates. Next, please. So the gist of all this is that it really is a combination of medicines. It's a recipe, if you will, that's specific to everybody. And it's dependent upon who you are, what your goal is, other medicines that you're on. As I say, that's why you come here. Otherwise, you could go to a pharmacy and just pick things off the shelf. That would be dangerous, probably. The L-carnitine and statin does lower the Lp(a). The studies show that if you can get that LDL down to about 60, the Lp(a) becomes much less important, probably because you just don't have as much. Next, please. Omega-3s. We talk about omega-3s all the time. Really, the studies are all about it being an antiarrhythmic. When we use omega-3s in the hospital in people who've had a heart attack, they have fewer arrhythmias. Who would think? Nobody ever talks about that, but that's really the documented effectiveness of the drug. They are antithrombotic and anti-inflammatory, although they've never really been shown, other than that antiarrhythmic, to have a long, we've never had a study where we go, oh, take your omega-3s, they save lives. We think it's like a little touch of this, a little touch of that, it can't hurt. But let's say you have a bleeding disorder. Or you're my father and you just had a brain bleed. You think I'm going to give him his omega-3s? Heck no, because it increases bleeding. You're going to go to the dentist. You may want to stop your omega-3s because it decreases thrombosis. So yes, it's good and it's helpful and it's preventive, but in the wrong context, it's not a good thing. Next, please. The PPAR regulated inflammatory markers are those. These are regulated by a particular hormone, and it's called PPAR. That's the HSCRP, endothelin-1, fibrinogen. There's a whole slew of them here. All of these markers are treated by Actos. Many of these markers are related to diabetes. We can measure these markers in this office. I've asked labs, they don't do interleukin-6, even Cleveland Clinic doesn't do that yet. But that, I think, is coming. I think interleukin-1 and 6 are coming. We do measure HSCRP, fibrinogen, PAI, and you can measure TNF, although we don't usually measure that, except in people. They may measure it in research in people who have collagen vascular disease, but it's not commonly measured. But the others we can measure, and you can actually show them get better. Actos, again, Actos, bad vibe, lowers blood pressure, increases adiponectin. That's a good thing. We'll talk about that more later. Decreases the onset of diabetes, improves endothelial function, decreases the composite evolved clotting, it decreases mortality, non-fatal MI and stroke, and it actually gives Alzheimer's protection. Now you tell me, do you want to take your Actos? Alzheimer's protection. And actually, that's very interesting. I won't get into too much detail, but for years we didn't think that there were any insulin receptors in the brain. Actose, insulin, actose, diabetes. What the heck is actose doing in the brain? Nobody knows, but it decreases the onset of Alzheimer's, and I've actually used it in some of my patients with dementia, and it works. And there's lots of studies on it. Go figure. Take your actose. Does it give you a little edema? It may. Okay, so take a little diuretic. Raise your legs at night. Obviously, if it causes too much of a problem, you stop it. But it has so many positive effects, particularly endothelial function. It just can't be ignored. It cannot be ignored. It's too important a drug. Next, please. The fibrates. We don't use the fibrates too much, but we do when we have triglyceride issues or when people can't take niacin. That's generally when we use the fibrates. They do decrease LDL, they increase HDL, they decrease triglycerides. They seem to reduce inflammatory cytokines, and they do decrease thrombosis, and they increase plaque stability. So they do have some benefit. But I'll tell you, the studies are just not as good. They're not as firm. They're not our first-line drug. Fibrates are like your Lopid, your Trilipics, those drugs. They really don't cause much harm. They do have they all go through the liver. We check the liver on everything. Obviously, if you're taking 2 or 3 drugs, your liver gets checked just as often. We don't ignore the liver. But truly, if you watch these things, you don't have a problem. Of course, if you give huge doses of any of this stuff and you close your eyes to it, you're going to find a problem. But you monitor what you need to monitor. Duh, right? Next. Other agents, there's Zetia. Zetia got a lot of press. And this was an interesting story because they were measuring that CIMT. But they weren't just measuring to see, does a person have disease? They were measuring it from time 0 to time a year or 2 later. And what they said was it didn't change. Again, I'm not sure that it's the thing to follow when you're talking about following inflammation. What they didn't measure was inflammatory markers. So Zetia, it was not a smart test because we had never proven at that point that that was a reasonable way to follow disease, and we still haven't proven that. But these, brilliant or not so brilliant people use that as their method of demarking whether it was a good drug or not, and they failed. The drug still lowers LDL. I think it has benefit, but it's not the same as a statin. It doesn't have the inflammatory ramifications, etc., like statins do. Practical advice. Now, we measure that apoprotein. Most of you in this room are ApoE33. Am I correct? Do you remember? ApoE is a protein on your is a protein that sits on top of those lipoproteins. And it helps define how cholesterol moves. How do we treat our fats and our cholesterol? How does it move between molecules? How is it distributed? This is the one place where diet makes a difference. If you're ApoE3, it's pretty much neutral. That's the good news and the bad news. If you're ApoE2, no refined carbohydrates. These are the guys that can eat more fats than carbohydrates. They do not do well with carbohydrates. And you can change your cholesterol pattern. You can change your LDL and HDL just by changing your diet. And we've actually had a patient where we've done this. So it does work. Alcohol is fine in a person who's ApoE2, and polyunsaturated fats are fine. Of course, I write in moderation because I don't want you to go think that, you can go have all the ice cream you want. Next. I mean, you can, but ApoE3, neutral. Good diet and exercise. But I'm not going to kid you that fats, that having a good diet and lifestyle changes are important to just general good health and maintaining good lipid analysis, but it's not as much of an impact as if you're ApoE2 or 4. Next, please. ApoE4 is the biggie. Low-fat diet, absolutely low-fat diet. These are the people, 15 to 20% fat in their diet, that's all. Low fat. So even the fishes that they eat need to be low-fat fishes. I don't advise omega-3s in these people. Maybe one omega-3 instead of lots of them. Really low fat. And here's the downer. No alcohol. Alcohol is a bad thing for these people. So exercise may or may not be of any help. and they definitely have increased risk of coronary artery disease, stroke, and Alzheimer's disease. So diet can make a difference. This is one of those places where diet changes things. So it's not just, hey, change your lifestyle, stop smoking. I think you really stick to this diet, you can use less drugs. This is where the impact is huge. The one place where it's huge. Next, please. This is a brief review, and I'll be happy to give this to you for anybody who is ApoE2 or 4, where it really matters. And you can see where fish oils in ApoE4, so you can't see that very well, but fish oils are just not a good thing. In ApoE2 and E3, they're a much better thing, but it actually decreases your HDL. So this is a place where their good cholesterol goes down when they eat salmon. Completely different than the rest of us. So ApoE4s are really the place where you can make a difference, where it really does matter. If you want to know if you're ApoE4 again and you don't remember, I'll check it for you, okay? I would have told you and we would have had this discussion already, but just in case you forget or you slept through that part. Next, please. Aspirin. Aspirin is great in prevention. It decreases the odds ratio of an event from 2.4 to 1.9. Very small increase in hemorrhagic strokes. We talked about that LP variant, that person who must take their aspirin. And if that's the case, I've told you. I've said you must take aspirin. If I did not say that, then that's not the case. In secondary prevention is the person who's had a heart attack or stroke. It's still beneficial. And I'll remind you that it decreases the risk of cancer. I've been using it for years. Everybody who knows me for years, you know I've been talking about this for the last 25 years. And I'm an aspirin, not an addict, but I'm an aspirin believer. Next, please. Now, some people are resistant. They don't use aspirin well. They don't have genetics that allow them to metabolize aspirin so that it's beneficial. If there's a question, if we really need aspirin, particularly in those LPA variants, what am I going to do? I'll measure whether the aspirin is working. And how do I do that? I'm able to measure its effect on platelets. That's where its effectiveness is. I can measure your bleeding time. And if you're an LPA variant, it's good to measure that bleeding time to make sure that the aspirin is working. Because if you need a double dose, you need a double dose. I mean, it's not a good thing to tell somebody you could live or die by aspirin and then not take enough. Duh. Right? So there are ways, we actually have means of measuring these things, and it is pretty sophisticated. But again, shit still happens. Next, please. The HAT study. I wanted to just again emphasize that I talk a lot about medications. I put you all on a lot of medications. You spend a lot of money. It matters. The HAT study was a study that was done in 2001. And it's just so important. What I want you to see here is the odds ratio. The event rate, it goes up as the bar goes up. Placebo is on the left. Look at the difference between the person who's on placebo and the person who takes the statin and niacin. Now, if that doesn't turn you on to taking medicine, what does? It takes the most common disease in the world and it makes it not so common. The AV is special kinds of vitamins, and then, of course, in the end, there's statin and niacin and special vitamins. The bottom line is your statin and your niacin saves lives. Look at that number. Again, this is the LDL response. It works with niacin. This was using simvastatin, that's Zocor. They use the LDL and ApoB response to niacin plus simvastatin. So on the right side of each of those little chunks is the diabetic. And the purpose of this is to demonstrate that it's very helpful even in diabetics. So even though we didn't show that statins necessarily change endothelial function and all those things that we know diabetics to have, it still is a very significant anti-inflammatory. That's why diabetics who've never had a heart attack go on a statin regardless of what their LDL is. Next, please. This is the IDL and VLDL response. You remember from last time we talked about there are various molecules that are atherogenic, and they're not all LDL. Some of them are IDL or intermediate lipoprotein, and VLDL, very low density lipoprotein. Again, you can see huge response both in diabetics and in non-diabetics as soon as you use the niacin plus simvastatin. In every one of those atherogenic molecules. Next, please. Niacin plus statin saves lives. This is the difference. Look at that curve on the right. 91% event reduction. There isn't any, you can't put money in the bank and know that you're going to get a return that's that's definite. Is that incredible? Now we had that study, and I say this because we had that AIM study that came out, and I sent you all of the information about it. Because that study used high-dose niacin, and the question was, does it save lives? And they weren't too sure. But they didn't measure who was taking their drugs or not. They didn't measure compliance. They didn't measure blood pressure. Well, duh, if a person isn't taking their medicines and they're hypertensive, maybe they will have a stroke. A useless piece of crap. And yet we spent 10 years on it. This study has stood the test of time and time again. And niacin is benign enough that if you can tolerate it, why not? Particularly if you're a diabetic and your HDL is low, if that myeloperoxidase is high, do you think I'm not going to tell you to take niacin? I am going to shove it down your throat. And the studies show that within a month, remember we talked about that Prove It study, that in a month people took Provocol or Lipitor and they took the bigger, the bigger drug, if you will, the bigger drug, the higher dose, and they lowered that LDL, and within a month there was a significant change in mortality. In a month! That's nothing. You can't ignore it. As much as this stuff is so confusing, and I'll be the first to tell you that I'm not sure that we have every evidence of what we're measuring, except it saves lives. And in the end, who gives a darn what test it is if it saves your life? I think it has to be put into the proper perspective. Next. Most every single study that's ever been done shows benefit. Every study. These are lipid drugs. These are all the studies on the right, and they all have various colors and shapes and sizes. But every one of them almost shows a decrease in events. Look at that line. So it does matter which drug. I think some are better than others. But the point is, they all demonstrate it to some degree or another. We don't have studies that don't show some benefit from acting on these inflammatory problems and stopping them dead in their tracks. Next, please. I want to talk a little bit about those ACE inhibitors that I talked about before, the Zestril, the lisinopril, and the fact that they are very important in that endothelial function. They dilate arteries, they reduce inflammation, they decrease clotting, they improve endothelial function, they decrease CIMT progression, they improve LV function. My goodness gracious. So when I say to you, I know you don't have hypertension, but I just want you to take a sliver of this drug, this is why. Keep that barrier strong. And these are the drugs that do it. Next. So this is the treatment compendium. What do I do if you want to treat high HDL, triglycerides, and subparticles, you use these drugs. LPA, you use niacin like we spoke about, statin plus carnitine, and actually estrogen, but not a man in this room is going to take their estrogen, even though it would make you a lot smarter. Fibrinogen is elevated, you use niacin, the phenofibrates are the Actos. ProBNP, that's the one that helps measure the function. Remember I told you that Coreg was good for function. There's Coreg, and of course there's your ARBs and your ACEs again, for function. Plaque 2, niacin, or omega-3s with a statin. Next, please. MPO, that's that myeloperoxidase, Actos, and perhaps niacin. Get on it now. Vitamin D deficiency, you take vitamin D. Insulin resistance, lifestyle, Actos, metformin, and the GLP-1s, that's Januvia and the drugs that I mentioned before. So, in summary, it just matters. I know they're expensive, I know they're a pain in the ass, but I also know they save lives. I'm not going to sit here and tell you that every test that we do is of incredible significance, but I am going to tell you that overall, I think we got it together here. And I think that, this is preventive stuff. And I'm not really interested in the oops moment. So we'll continue to measure. We'll continue to make sure you're safe. I'll ask you to improve your lifestyle. Have a glass of red wine unless you're ApoE4. Enjoy your life. Because I will tell you, when my father had his event last week, every day does count. And you never know.